Thank you very much for this opportunity to be able to speak to the membership of the Nebraska chapter during your annual meeting. First and foremost, I must give my thanks to my dear friends, Dr. Marvin Bittner, the immediate former governor who was governor of my class, and current governor, Dr. Micah Beachy, for the invitation to come and speak at this event. My topic today is going to be on the current ACP initiatives and policy actions. And I'm going to start first of all by giving you a content overview of what I'm going to talk about. We'll first start with looking at ACP as a glance and just look at the structure of the organization and its membership. Then we're going to go into ACP's vision for the U.S. healthcare system that was launched at the beginning of this year. And then we'll talk about the COVID-19 pandemic and what ACP is doing to support members in the internal medicine community. And then we will look at other initiatives within the organization to transform the landscape of health for the better. And then we will look at educational and additional resources that the ACP has provided for members and for the internal medicine community as a whole. And then look at opportunities for involvement, engagement, and connection for the general membership. So let's start by looking at ACP as a glance. Who are we? The college was established in 1915 and grew to become the largest medical specialty organization in the United States. We currently have, I think, about 163,000 members and growing. Our membership is distributed throughout the world in 145 countries, and we represent a diverse global community of internists, internal medicine subspecialists, residents, and fellows in training, and medical students as well, who are all unified by this commitment to excellence in patient care and in medicine. To look at the structure of the organization, I will go ahead and use the voice of Wayne Bilsner, our Chief Operating Officer, who quite eloquently describes the structure of the organization in the next slide.
I'd like to begin with this slide, which provides a good overview of ACP. At the bottom, the foundation of the college, we have our 154,000 members who are diverse and worldwide, coming from 145 different countries. Over 10% are outside of the U.S. Our 86 chapters provide a local presence for these members, as well as a way for them to interact with and impact the national organization. Each chapter is led by a volunteer, ACP governor, and collectively these local leaders comprise the Board of Governors, a body connected to ACP's grassroots and that is advisory to the Board of Regents. The Board of Regents is the body responsible for setting ACP's course and keeping it on mission. To help the board do its work, the board has charged over 20 committees and councils, and they provide critical recommendations and do much of the work that leads to the policies, programs, and products that the board approves and that define the organization and provide value to members. Not depicted here is ACP staff who provide input and lead implementation for each of these components.
So who are we as internists? An internist is an internal medicine specialist. This is a clinician who applies scientific knowledge and clinical expertise to the diagnosis, treatment, and compassionate care of adults across the spectrum, from the healthy individual to the patient with complex multi-system illness. We stand for leveraging the collective voice of our community to create a better place for ourselves and our profession and for our patients through continued medical education, practice transformation, advocacy, and engagement. I want to touch on ACP's priority themes for the current year. We would like to create a valued professional identity as a community of internists and create a shared enthusiasm and pride about being an internist and an ACP member. And in so doing, we would also like to increase the number and engagement of ACP members who have completed their training. That is not to say that our in-training membership is less important. They are our best asset because they become the pipeline for ultimate ACP members. We would also like to increase our diversity, inclusion, and engagement activities so that we can support inclusion in healthcare and welcome and hear all voices and actively engage diverse members in local, national, and global college activities. In fact, with our global footprint, we are the best set to be an anti-racist organization, as we have members from virtually all nations in the world and all cultures. We also want to be innovative, and we want to use nimble, creative, and unique approaches to identify and respond to member needs and to develop new programs and products and services that are focused to meeting these needs. As such, we want to drive systemic change in healthcare to support physicians in providing the best possible care and adapt ACP's cultures and operations to a COVID and post-COVID global environment. This slide just reflects and illustrates our global membership. We have members on every single continent, and we have chapters virtually in every single continent. And there are many countries that do not have chapters but are represented by chapters in other countries to which those members are affiliated. And the list of chapters listed here is actually incomplete. There are actually a few more chapters than those that have been illustrated here. In terms of diversity, equity, and inclusion, the ACP's vision, goals, and core values were revised at the beginning of this year to better reflect the fact that diversity, equity, and inclusion are essential and valued pillars of this organization. These vision, goals, and values are consistent with the revisions to this policy, and the ACP's belief that a commitment to diversity, equity, and inclusion strengthens the organization's capacity to respond to the needs of its members, its patients, and the profession and the public. Therefore, with our mission to enhance the quality and effectiveness of healthcare remains unchanged, the goals and vision and goals now ensure that ACP's approach to inclusiveness is very clear and is clearly communicated and understood to be foundational to the college. Our membership is truly diverse, not just in culture and ethnicity, but in age and professional standing. We have medical student members, resident fellow members, full members, fellows, physician affiliate members, and non-physician affiliate members as well. That might include nurse practitioners and other folks who are engaged in the care of patients together with internal medicine physicians. So let's turn now to looking at ACP's vision for the U.S. healthcare system. It's entitled Better is Possible and was launched at the beginning of this year with a series of manuscripts that outlined ACP's general goals. But a general view is that there are three pillars to this vision. ACP recommends a comprehensive reform of the U.S. healthcare system to ensure coverage and affordability, to ensure effective and efficient payment and delivery systems, and to reduce barriers to care and address social factors impacting patients' health. This vision came as a result of a very long look at the U.S. healthcare system with this whole bunch of questions that folks asked. What would a better healthcare system look like? And in this, we should ask ourselves several questions, and this list is not by any means comprehensive. First, why do so many Americans lack coverage for the healthcare they need? Why is U.S. healthcare so expensive and therefore unaffordable to many? What barriers to healthcare, in addition to coverage and cost, do patients face? And how do delivery and physician payment systems affect costs, access, quality, and equity? And you don't really have to be a genius to find answers to some of these questions, including the fact that our healthcare is too expensive, leaves too many without coverage, spends far too much on administration, results in inequitable outcomes, undervalues primary care, and undermines the patient-physician relationship. Our system also enables social and economic circumstances to dictate health, and there's a lot of underinvestment in public health. In a nutshell, the healthcare system as such is failing millions of Americans, and it is really time to challenge the status quo. At the beginning of this year, the college published its vision for the U.S. healthcare system, which was entitled Better is Possible, the American College of Physicians' Vision for the U.S. Healthcare System. And this was published in a series of papers in Annals of Internal Medicine around about January of this year. And it included 4 papers. First of all was a call to action from the ACP. And then there was an article discussing coverage and the cost of care. A third article discussing the reduction of barriers to care and addressing social determinants of health. And then a fourth article that dealt extensively with healthcare delivery and payment system reform. The process for developing this new vision was fairly extensive and involved a lot of stakeholders. The Board of Regents first asked the Health and Public Policy Committee and the Medical Practice and Quality Committee to develop a new vision for the future of healthcare policy. The college then examined ways to achieve universal coverage, improve access to care and lower costs, and reform payment and delivery systems, and reduce the complexity of the healthcare system, and then consider the effectiveness of other countries' healthcare systems vis-a-vis our own. In addition, the ACP solicited inputs from all US-based members through a survey, and more than 1,000 recommendations were received and shared with the committees that were developing this new vision. And then the ACP also solicited input from all of its policy and technical committees, and then also had buy-in from regents, governors, council members, and then prepared finalized recommendations and submitted them to the Board of Regents for approval. So, in a nutshell, ACP envisions a healthcare system where everyone has access for and access to the care they need at a cost that the country can afford. Social factors that contribute to poor and inequitable health should be ameliorated, and we should remove barriers for vulnerable and underserved population so that no person is discriminated against based on characteristics, socioeconomic status, or other elements of personal identity. We do need to develop payment and delivery systems that put the interests of patients first and support physicians and their care teams in delivering high-value and patient-centered care. Spending that is currently redirected to unnecessary administrative costs really should be channeled to research, public health, and other interventions that address social determinants of health and improve the well-being of patients in general. And then clinicians and hospitals should deliver high-value and evidence-based care within available resources, as determined through a process that prioritizes and allocates funding and resources with the engagement of the public and physicians. Additional elements of this vision is a system where primary care is supported with a greater investment of resources, and payment levels between complex cognitive care and procedural care are equitable. We are very, very aware that the average primary care physician is not adequately remunerated for very detailed, complex care, where other procedural care elements are remunerated at an extremely high level with minimal intellectual or even resource input for the physician providing the service. We do need to align financial incentives to achieve better patient outcomes and to lower costs and reduce inequities in healthcare. And then we do need to free the patients and physicians from administrative burdens. These include billing tasks and documentation requirements that do not add any quality to the care the patient is receiving. Simplified payments and charges that are more transparent and predictable are a cornerstone to this, and delivery systems should be redesigned to make it easier for patients to navigate and receive the care they need. Value-based programs that incentivize collaboration among clinical care team-based members should be used, and evidence-based and patient-centered measures should be adopted when providing care in these environments. And then health information technologies, of course, should enhance a physician-patient relationship and facilitate communication rather than impair them. So the vision that says better is possible looks at each of these distinct elements. And I'll just talk briefly about some of them. Some of these slides are pretty busy and therefore may be a little bit tedious to go through every single element. Let us first start talking about the single most contentious piece of this, which was the question of coverage and cost of care. The ACP recommends transitioning to a system of universal coverage with low administrative costs through either a single payer system or a public choice option to be offered along with regulated private insurance. Now, when this statement came out, there was a lot of, shall we say, brouhaha about this statement. Because it seemed that the ACP was advocating either a, quote, socialized medicine or Obamacare or all of the other bogeymen that have been invoked in the healthcare debate. But really, the ACP's position is fairly simple. We want a plan or a system where all persons should be enrolled and where essential benefits are covered for everyone. We should also have basic essential benefits established through a process that includes physician and patient engagement. And then we also need to have a cost sharing plan that removes barriers to evidence-based high-value care with coverage for patients with certain defined chronic and catastrophic illnesses. So whether we go with a single payer system or a public choice option, we would be able to end up with a substantial reduction in administrative costs and reduced burdens on physicians and patients. So other elements of cost control could be achieved by prioritizing spending and resources, lowering excessive prices and price variation, and we're very familiar with all of the different shenanigans pharmaceutical companies are using to increase the prices of various essential medications. We would also want to increase price transparency and increase adoption of global budgets and all payer rate setting. We would also advocate for reduction in administrative costs while promoting high-value care and incorporating cost and cost comparative effectiveness into guidelines of coverage, which we are not effectively doing at this point. And finally, a greater investment in primary care is going to result in a general reduction in costly care by other specialized physician services. Now, there is no one-size-fits-all approach to reforming delivery and payment systems. We are all very aware of that, and the robust debate over the last 8 to 10 years around the Affordable Care Act is a testament to that. There is a diversity of opinions and diversity of views as to how this can be done. However, I think there are some common sense and basic understood elements to this. Increasing payment to primary care physicians and cognitive services will increase our pool and attractiveness of primary care for our graduating residents, and hopefully they will be able to provide better and more cost-effective care to their services. We really need to redefine the role and performance measures to focus on value to patients rather than on other nebulous elements. And we want to remove the checkbox reporting of clinical measures where they are not of any use to the patient. We also need to align payment incentives with better outcomes and lower costs and eliminate unnecessary or inefficient administrative requirements. One of these, for example, has been the documentation requirements that are the bane of the internist, where many internists report spending twice as much time documenting as they actually spend face-to-face with a patient. And then, of course, we would like to redesign the healthcare information technology to better meet the needs of clinicians and patients, as currently many health information technology systems are more geared toward billing and organizational efficiencies rather than patient care. In terms of addressing disparities to care, ACP calls for an end to discrimination and disparities in access of care based on personal characteristics, correcting workforce shortages, and understanding and ameliorating the social determinants of health. We believe that all persons, without regard to personal characteristics, must have equitable access to high-quality healthcare and must not be discriminated against or must not face barriers that discriminate against them based on personal characteristics, whether it is gender, race, or employment status. We also call for increased efforts to address urgent public health threats, that including injuries and deaths from firearms, environmental hazards and climate change, maternal mortality, substance abuse disorders, and health risks associated with nicotine, tobacco, and a new emerging threat, the electronic nicotine delivery problem. So Dr. Gawande wrote, "Better is possible. It does not take genius. It takes diligence. It takes moral clarity. It takes ingenuity. And above all, it takes a willingness to try." Are we as an organization willing to try? Are we as an organization willing to go out of our comfort zone and ask the difficult questions and put forward the unpopular proposals? The ACP rejected the view that the status quo is acceptable or that it is too politically difficult to achieve the needed change. And by articulating this new vision, the college is showing a willingness to try to achieve a better U.S. healthcare system for all. We would therefore like to urge all physicians to join us in envisioning a better U.S. healthcare system for all, as in our call to action. And you as a member can join the ACP by stating that the status quo is unacceptable. Please make your voice heard. Help spread the word on social media by using the hashtag ACP Vision for Healthcare and discuss how these policy recommendations can help create real change. You can also visit annals.org and read the vision papers for yourself, or visit acponline.org/new vision for more information about these public policy releases. Now, the ACP, of course, has not just focused on one piece. ACP has also had additional public policy releases over the course of the year. We advocate for changes that will make differences in the daily lives of internists and our patients' health. And these include a recent prescription drug paper where we have policy recommendations to promote prescription drug price competition. We also have put forward a policy on racism and health, basically looking at racism and health in the United States and its impact on the health of our populations. We have a few other papers on prescription drugs and policy recommendations to stem the escalating cost of prescription drugs, and also recommendations for pharmacy benefit managers to stem the escalating cost of drugs. And then, of course, our firearms call to action, which came late last year and was subject of quite a bit of publicity. And I would urge you to go ahead and read the ACP Advocate for in-depth coverage of advocacy and regulatory news, and to see some of the things that the ACP has been doing on your behalf and for you. We continue to collaborate with other organizations, and this photograph is actually a photograph of the so-called Gang of Six, including leadership of the American College of Physicians, the American Academy of Family Physicians, the American Academy of Pediatrics, American College of Obstetricians, American Osteopathic Association, and the American Psychiatric Association, who have gone together to Congress, to the Hill, to lobby on behalf of physicians, patients, and members of the various organizations. And this has been a really effective group, as they have carried the full weight of the physician community to those offices as they go to push forward initiatives that are essential to our professional interests. So ironically, as the college was pushing forward its vision for a better healthcare system, a COVID-19 pandemic was blossoming around the globe. And subsequent to that, early in the year, the ACP was forced to pivot to start looking at how they're going to support the members and the general community in the middle of this massive and unprecedented public health crisis. So the ACP started off with several programs right away that were intended to educate and provide information and tools for its membership to help them survive the crisis, but also help them better take care of patients, especially in light of the fact that this pandemic was due to a new and previously unknown virus, and that the manifestations of the illness were previously unknown and unprecedented. So the ACP created a comprehensive resource hub, which is still open and still contains a lot of information. And it also developed real-time protocol to update clinical tools and practical information for physicians to use as they cared for these new patients. The ACP also developed new policies to address new situations and circumstances that occurred as a result of the pandemic, and also started vigorously advocating to address ACP members' needs and patient needs. There were webinars, there were podcasts, there were frequent publications in annals, there were discussion fora, and the ACP also sought to regularly update the membership on information that was pertinent to their care for patients with COVID-19. So the COVID-19 Resource Hub is available online. You can access it through the web portal, through acponline.org. And you can also look at the Physician's Guide, which is mobile friendly. You can download it on your phone, or you look at it on your computer, or have it on your desktop. It's a very good resource for issues around infection control, patient management, and of course it is updated frequently as more and more information comes in. The pandemic also forced us to start looking at alternative care models, and one that has really grown is the telehealth and telemedicine use in patient encounters. The ACP has provided online resources to help physicians implement telemedicine, and I think most physician practices now are quite facile with telemedicine and telehealth technology. But there's also a lot of resources on telehealth coding and billing, which is slightly different from your regular face-to-face billing, and then information about coverage rules and technology options in telehealth are also very important and be provided by the ACP. During the COVID-19 pandemic, practice management began to differ as patients moved away from in-person visits to telehealth visits. And therefore, there are resources that cover coding and billing, payer policies around phone calls and testing and cost sharing and prescription and enrollment. There are also financial and management issues in practice management. And of course, things like COVID-19 immunization and how to safely administer vaccines during the COVID-19 pandemic. And the ACP also initiated a PPE partnership with Project N95 to secure PPE for ACP members. And we're going to look a little bit at this and see how successful that program has been. As the country moved back towards a reopening and recovery, the ACP also developed resources for physicians and practices to help them recover from the initial shutdown. Resources included innovative staffing models, workflow modifications, testing strategies for patients coming to the office, and for patients, communication templates for practice communication, FAQs, and infographics on where to seek non-COVID care due to the pandemic. Some of these resources are actually available in a downloadable format, both for physicians and patients. Now, we talked a little bit about the PPE program that the ACP promoted for members. The partnership actually resulted in more than 2,500 members ordering up more than 220,000 masks, 93,000 gowns, and more than 15,000 face shields to cover more than 60,000 staff. So this was quite a considerable effort by the ACP that helped to bridge a gap between publicly available supplies and the needs of the physicians, especially in that critical phase. So by August of 2020, this program has really helped physicians and practices meet that gap. And I think the program will continue to avail these resources to physicians and staff as needed. Now, the ACP also responded to the COVID-19 crisis by promulgating a series of policies, and these were around infection control, but also around some of the other social events that came up as a result of the COVID-19 pandemic. So first of all, there is an ACP policy that supports wearing of masks to reduce the transmission of COVID-19. There is also a policy on partial resumption of economic, healthcare, and other activities while mitigating COVID-19 risk. And then prioritization, allocation of resources, and stewardship should not result in discrimination. And then one of the things that we also saw was an increase in harassment and discrimination against, in particular, folks of Asian descent. And the ACP passed policies that basically pointed out that harassment based on race or ethnic origin is never okay, even in the midst of the COVID-19 pandemic. There was an outcry amongst physicians that they were unable to use their own PPE in healthcare facilities, especially during the crisis and the shortages. And some institutions pushed back against physicians bringing their own PPE. And the ACP came out fairly strongly and indicated that physicians should have the right to bring their own PPE, especially if their employer or employers cannot provide them. And then the ACP also came up with social distancing recommendations to help slow the spread of COVID-19, and also policies about non-urgent in-person medical care, which could be transitioned to virtual care. The ACP also initiated a series of living practice points that were designed to promote high-value care on the best available evidence from assessment of scientific data. And this evidence was updated as new information became available. This was a really valuable resource for memberships especially in the light of the lack of information during the COVID-19 pandemic. So recently published practice points, for example, was looking at the effectiveness of N95 respirators, surgical masks, and cloth masks in healthcare and community settings for the prevention of COVID-19. Or alternatively, the question as to whether clinicians should use chloroquine or hydroxychloroquine alone or in combination with azithromycin for prophylaxis or treatment of COVID-19. These living practice points have continued to provide very valuable evidence-based information for physicians to use as they care for patients under very complex conditions. The ACP's advocacy arm has continued to work hard during the COVID-19 pandemic and has achieved several wins that will help internists in their practices. For example, ACP lobbied for pay parity for telehealth and telephone call services from Medicare and private payers, and these organizations have actually loosened restrictions for these services, enabling physicians to seamlessly provide telehealth services to their patients. We also have a program where payments to practices would not need to be paid under the Provider Relief Fund, and additional funds could be accessed as loans through the Medicare Advanced and Accelerated Payments and the Paycheck Protection Program. We also have lobbied for coverage for COVID testing and treatment through the CARES Act, and of course the very well publicized Defense Production Act, which increased the production of personal protective equipment after being invoked by the administration. ACP's advocacy continues, and one area we're still looking at is the increase of availability and processing of visas for international medical graduates to beef up our primary care workforce, as well as looking at making permanent the flexibilities that have been granted for telehealth services and to have them remain in place even post-COVID. The Annals of Internal Medicine has a collection of articles that provide more information on COVID-19. In addition to research articles, there are commentaries, essays, podcasts, and graphic narratives, and these are freely available to the public, but also, of course, to our membership at annals.org. Now, one of the interesting things about the COVID-19 pandemic is that it has actually raised our awareness of certain ethical issues that have come up during the pandemic. The ACP responded to some of these issues by issuing policies and also, in a sense, working on its advocacy arm as well. There's an ACP policy on non-discrimination in the stewardship and allocation of resources during health system catastrophes. There are ACP policies protecting patient and physician health and safety during the COVID-19 pandemic, and we saw this coming up very, very seriously, especially with regards to the shortages in PPE and issues around whether physicians and other healthcare providers could continue to work in an environment where they are not adequately protected from infection by COVID-19. The ACP also published a wake-up call for healthcare, which is looking at emerging ethical lessons from the COVID-19 pandemic. And this was a joint publication by the ACP and the American Medical Association. And then there have been multiple ideas and opinions that have been published in the Annals of Internal Medicine, which I would urge you all to go and look at. In particular, there are issues around universal do not resuscitate orders, issues around the social worth for our patients and life years, and then opposing discriminatory approaches to allocation of resources during the pandemic. During COVID-19, we also have some dedicated podcasts that are highlighting various aspects of patient care and prevention of infection by COVID-19. And some of these are from the Infectious Disease Society of America that the ACP has worked together with them to provide through our portal. And then, of course, we have member discussion fora with webinars and telemedicine and practical advice and support for internists as well. So one of the other important things about ACP's response during the COVID-19 pandemic is highlighting the essential role of internists during the COVID-19. Really, this pandemic, more than anything else, has brought to light what we have always known, that we are essential. We are the backbone of the healthcare system. We are the ones who take care of the bulk of inpatients. And if I was to give an example at my particular institution, and as we have looked at the growth of hospital medicine at my institution, we are now caring for virtually half of the entire census of the hospital population. And if you add ICU care and other specialized units that have been really brought to the forefront during the pandemic, you really see the utility of the internist. You can do an ophthalmic nerve transplant, but God help you if you cannot manage a ventilator in the middle of a COVID-19 pandemic. And so we have really shown our value to the community, and we would like all internists to feel proud and to feel essential and to realize that we are the backbone of the healthcare system. So I want to switch gears just a little bit to talk about how ACP is working for you and with you, especially with regard to transforming the landscape of healthcare for the better. One of the things that the ACP is particularly concerned with is the personal well-being and professional fulfillment for physicians practicing internal medicine. We now offer fulfillment activities and professional promotion activities free to ACP members, and we have set forth the I Am Thriving movement, for want of a better word, which is designed to promote well-being and professional fulfillment activities. And some of these activities actually have CME built in. So they include the mini but mighty skills for well-being, practical advice and support on the front lines, positive psychology in times of crisis, and also optimizing well-being, practice culture, and thriving in an era of turbulence. These are really designed to help physicians become more resilient, but also to take time and be mindful and generally take care of themselves as they work through really, really challenging times, especially with COVID-19. Another important initiative for the ACP is promoting gender equity and eliminating inequities in compensation and career advancement through the Women in Medicine initiative. ACP has joined the Time's Up Healthcare, and I would urge all of you, if you're not already familiar with the Time's Up movement, to look it up and join the Time's Up movement in healthcare. The ACP is also a partner in the Women's Wellness Through Equity and Leadership Project, and the Diversity and Inclusion Subcommittee has all made recommendations on strategies to assure integration in diversity and inclusion across the college. That includes both gender diversity and racial and ethnic diversity. Ethics is another area where the ACP has produced resources and advice on personal and professional improvement. There, of course, the American College of Physicians Ethics Manual is available online for all of us to download and review. But we also have an ACP position paper on ethical guidance for electronic patient-physician communications, which helps to align expectations between providers and patients. We have Spanish translation of the ethics manual, and then there are a few other papers, for example, case studies produced on electronic health records, a position paper on physician impairment and rehabilitation, looking at reintegration into medical practice, and then, of course, we have expanded content in the 7th edition of the ethics manual. And I would urge all of our members to take a look at the ethics manual, look at ACP's positions on various ethical dilemmas that face our societies today. Another area that the ACP is working on is the future of MOC. And for our younger members of the audience here, in particular, the medical students and residents, the American Board of Internal Medicine requires internists to continue through a process of maintenance of certification, also known as MOC. And over the last 5 to 10 years, this has been an area of contention as the general physician community has felt that the MOC requirements through the ABIM have been onerous and not necessarily geared to professional practice improvement. The ACP has really taken on the mantle of pushing back against the ABIM and advocating for internists to better streamline the MOC process and also make it more aligned to practice improvement and patient care. So the ACP is really pleased that the ABIM has taken steps to develop a continuing certification process rather than a drop-dead single examination for recertification. And this continuing process will support lifelong learning and will emphasize education and feedback and the convenience of a self-paced learning and testing process. Now, in addition to that, the ABM has a plan to develop a longitudinal assessment as an option in addition to the so-called point-in-time examination. And this is in line with the recommendations of the American Board of Medical Specialties, recommendations on continuing certification. The ACP is really committed to ongoing professional development and lifelong learning, and its activities to modify the MOC process with the ABIM should really not be construed as moving away from this process of ongoing professional development. We want our physicians to continue to improve and to be professionally accountable as they care for patients. And the ACP will continue to work with the ABIM in developing other options that emphasize learning and offer flexibility of choice, and that will meet the need of internal medicine specialists and subspecialists and the patients that they serve. And so hopefully, for those of you residents and medical students who are in the audience, by the time that you are coming into practice, we should have a much better and streamlined maintenance of certification process that should really start the moment you get your license and get certified to your last day in practice 100 years from now. Continuing along the theme of working for you and with you, I want us to look at some of the educational resources that the ACP provides for our membership. First and foremost, our flagship journal, the Annals of Internal Medicine, is available to all of our members for free. The Annals is one of the most highly read and cited medical journals in the world and provides current evidence-based science at your fingertips. There are various useful elements to the Annals journal, including audio on demand, where you can get Annals on call or the latest podcasts. There's a Fresh Look blog, there's a Story Slam, and there are insightful content. For example, the Beyond the Guidelines section, which delves into the guidelines and gives practical advice as to how to apply these guidelines. Additional content include the consult guides, graphic medicine, which is a really picture snapshot, so to speak, of a particular important piece in the journal. And for those of you in medical education, Annals for Educators is a very vital resource. And again, a copy of an element of the Annals that is dedicated to the hospitalist, the Annals for Hospitalists, is a really useful piece, and I've really found it very useful for me in my practice. Another important ACP publication is a Mix App, which for many years has been the go-to resource for board prep and also for lifelong learning. I have a copy of the current Mix App 18 on my desk, and I use it every single day to review, research, and improve on my knowledge, and it never gets old. It absolutely never gets old. It is available in print and digital, and also provides you with CME and MOC points. And if you purchase the Mix Up 18 book, you also have access to the digital content. My favorite consumption of Mix Up 18 is actually on my iPad, which I can carry around with me and use for either reference or for study whenever I have a downtime during my day. The ACP also provides a lot of clinical guidance, evidence-based clinical guidance. For example, clinical recommendations on the treatment of non-low back pain from musculoskeletal injuries, testosterone screening in adult men with age-related low T, screening for colorectal cancer in average risk individuals, and managing conflicts of interest in clinical studies. The ACP has been named to the Cochrane US network that consists of some of the country's leading institutions in the research and practice of evidence-based medicine. ACP also provides a gateway to CME through an online module. You can access this again through acponline.org. It's a centralized gateway to more than 350 online learning activities, many of which are free to members. They include video-based learning, journal articles, mix-up questions, content on point-of-care ultrasound, podcasts, ethics case studies, and high-value care cases. In addition, we have the ACP CME 30, which features curated online features from scientific practice-related sessions originally scheduled for live presentation at the Internal Medicine 2020. These are now availed for CME credit and mock points for each recorded presentation. So they cover all of the elements of internal medicine, and I would also urge all of you to look it up and look at some of the valuable content that was created by some of our esteemed professionals. There are virtual live courses that you can also take, and these are really designed for board review. They are designed for those of you who are needing to either take the ABIM for the first time or those who need to recertify. The courses are designed and taught by expert faculty who are really aces in the board review process. They are real-time and effective board prep that's convenient and safe, and they provide very comprehensive internal medicine content with tips for test taking, as well as CME and MOC points for those who attend the courses. Another area of personal professional development is point-of-care ultrasound education. The ACP recognizes the important role of POCUS to improve diagnostic capabilities in internal medicine and offers these modules for self-training and development. The modules are fairly comprehensive. They include instruction on obtaining adequate clinical images for interpretation, and they also include specialized content on lung and DVT, urinary system, and abdominal imaging, as well as focused cardiac imaging. You can access these modules through the acponline.org, and if you just go to the acponline.org/POCUS, you can get there directly. I also want to draw your attention to podcasts that are availed for internists. These are podcasts by internists for internists, the Bedside Rounds, Core IM, Annals on Call, and there are a few other useful ones I think I mentioned earlier on, the Consult Guys as well. These are really great for you when you're doing things like household chores or exercising or just taking a walk with your dog. If you have these podcasts available, they're free and they can also offer CME and MOC points as well. So please take a look at these podcasts that are availed through ACP Online. And then there are a bunch of different publications that ACP puts out. Of course, there's the ACP Internist and the Hospitalists, which are print publications. And then there's the acpinternist.org and hospitalist.org, which are online. There are newsletters and, of course, a whole host of books that the ACP has published that specialize in internal medicine and general internal medicine and internal medicine subspecialties as well. Now, Dynamed is also a free benefit for ACP members that provides point-of-care clinical decision-making support. This is a resource that's been developed for a very long time, and access was provided to ACP members for free. And access to Dynamed really has been extended until 2023, free to members. I think at that point, beyond 2023, a decision will likely be made as to whether you have to pay separately for Dynamed. But for those of you who are in the practice arena and wanting to look at different practice points and evidence-based medicine, Dynamed continues to be a very useful resource for you as well. And then another member benefit is the ACP Journalwise, which is basically a resource that searches through more than 120 journals and looks for content that is relevant to you. So there are filters that you can use to rate the clinical newsworthiness and relevance of each article, and then these articles will be provided to you, usually through a daily email that you can access. For those of us who are a little longer in the tooth, especially those of us involved in medical education, there are additional resources that are available as well. The Board Basics 3 and the courses associated with clinical images and content will help you with ABI exam and recertification and MOC preparation. And educators will have a whole series of resources on teaching in medicine. the so-called Teaching in Medicine series. And of course, the Annals of Internal Medicine continues to provide information with teaching tools, in-service training exam for residents, and board prep curriculum for residents, as well as information on high-value care for trainees at all levels. Finally, this section on working for you and with you cannot end without looking at your involvement and your engagement and opportunities to connect through the ACP. I mentioned earlier on the I Am Proud movement. We would like all of our members to show their I Am Proud. I have shown my I Am Proud. If you go into YouTube, you will see a video of me saying why I am proud to be an internist. Would like to encourage everybody to reflect on and ask themselves why or what are they proud of as an internist, and let the world know that you're proud to be an internist. We want you to continue to engage with the national ACP, and one of the things that I really like to promote amongst my members is advancement to fellowship. Fellowship recognizes your excellence in the practice of internal medicine and your professional accomplishments. So if you are a resident, please plan to advance to fellowship within 3 years after you graduate residency. If you're a practicing physician now, recently out of residency, please plan to put in your application for fellowship within 3 years after graduating residency. The other thing we would like to do is to support the next generation of internists, and remember that our students and our residents are our greatest resource. There are member forums where we can engage with colleagues on clinical topics, education and training. And then the ACP also has an active member engagement program, which enables members to contribute to college activities while providing meaningful opportunities to use their current skills and knowledge and gain new ones. We would like all our members to join the Advocates for Internal Medicine Network. This is a grassroots advocacy network that helps the ACP members engage with federal lawmakers on policy issues. AIM members receive legislative updates and alerts, and also participate in our legislative events every year in Washington, D.C. And this is, I can't remember which chapter this is, but this is one of our chapters with all of the faculty and students who have gone to lobby their respective representatives in the House of Representatives in Washington, D.C. So this is another way that as an ordinary member you can engage your ACP leadership as well as the national leadership at the highest level to advocate for policy issues that are close to us in terms of our professional practice. We also want to promote the I Am Power. This is communications that are centered on the unique needs of residents and fellows in training. This gives you podcasts, learning modules, chapter articles, and ideas for local programs and things that you can do. It also includes non-clinical topics such as decision-making as a resident, financial planning and maintaining well-being during residency, and tips and content specific to the training year. I actually recommend this not just for residents, but for medical students as well. And these are all visible and available to you through the acponline.org/IamPower. And then we'd like to encourage everybody to enhance their professional development through the ACP. The ACP Leadership Academy provides formal leadership education sources. This is really useful, particularly for early practice physicians and young faculty. We also have mentoring and networking at the chapter and local levels. We have the Young Achievers program, and we also have a career connection that gives a listing of career opportunities that are available for physicians. And again, for residents who are looking at their first job, this may be a very useful resource to see what is out there. The ACP also provides financial services. There is a professional liability insurance program for ACP members. There's an ACP group insurance program, and there is also a student debt refinancing program where ACP members can refinance existing private and federal loans through SoFi, and these are eligible to receive a 0.125% rate discount upon refinancing the student loans. And so this is not just for students, current students, but this is for graduated residents and fellows who still have student loans to pay off. I would like to urge everybody to get connected. Lots of ways to connect with the ACP through Facebook, through Twitter, through Instagram, LinkedIn, and also through YouTube. We would like all our members to be engaged and get connected through social media. Many of the chapters, including the Nebraska chapter, have a significant online presence. Please follow your chapter. I follow the Nebraska chapter, so there is really no reason why you cannot follow the Nebraska chapter on Twitter. And Dr. Bittner's posts are also always quite entertaining and informative, as well as the other posts from the chapter. So I urge everybody to make sure that they have a presence online and that they follow the different chapters and the national organization online in social media. So I want to end with a thank you to everybody for their continued support of the ACP and their continued commitment to the practice of internal medicine and their dedication to the profession of medicine as a whole. The American College of Physicians is there for you and will work with you and for you to enhance your practice and enhance the care of our patients, because that is the reason that we are here. Thank you all very much.